Good evening, everybody, and welcome to EUROGEN webinar series. I'm Michelle Battye, and I'm the Programme Manager of the EUROGEN network. So EUROGEN is one of 24 European reference networks created and funded by the European Commission since 2017. And we deal with rare urogenital diseases and complex conditions. And the aim of an ERN, really, the aim of our ERN is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions who all need highly specialised surgery. So really where the expertise is rare. So some of the activities that all ERNs offer are virtual consultations cross-border using a secure IT platform called the CPMS, the Clinical Patient Management System. And you saw some slides about that at the beginning of this webinar. So please, I would really encourage any of you out there who has a complex case, please feel free to get in touch with our ERN, and the experts in our network would be very happy to help. And we're currently a network of 56 healthcare providers located in 20 member states. So all our surgeons are collaborating on giving advice. We also have a number of training and education activities like this webinar programme. We collaborate on producing clinical guidelines on the rare and complex areas. And we have recently produced a fantastic book. So I do encourage you all out there to do look it up and buy it. It's called Rare and Complex Urology. So this really is the synthesis of all the work that the ERN has been doing since 2017. And finally, very exciting, we have a EUROGEN patient registry. So we all know that one of the main problems with rare diseases is fragmented and scattered data. So the registry hopefully will pull all of this data together. So it'll be a very important source of real-time clinical data moving forward for research and also as the evidence base for the clinical guidelines. So without further ado, tonight's webinar is part of our colorectal series of webinars, which we produce in collaboration with ERN, which is a sister ERN of ours, which deals with inherited and congenital anomalies. It's also supported by the European Pediatric Surgeons Association and the ARMNet, so we thank them always for their kind support. So tonight's webinar is about anorectal malformations and sexuality, and our presenters tonight are Dr. Marieke Witvliet, and she is a psychologist and sexualogist. She's a pediatric surgeon at Wilhelmina Childrens Hospital at the University Medical Centre in Utrecht. And then we also have a psychologist and sexualogist who is Dr. Stefano Eleuteri from the Sapienza University of Rome. And they both have an interest in quality of life research and research on sexuality of patients with an anorectal malformation. So we really thank both of our presenters for sharing their expertise with us this evening. So Marieke, I'll give you the floor. Thank you very much for being here with us tonight.
Thank you very much for having me here. I'm now gonna put on my presentation. Is it visible for everyone in a good way?
That's perfect, yeah, Marieke, yes.
Perfect, great. Well, first of all, what I just said, thank you for inviting me, because I really like this topic, and it's such an important topic to think about sexuality in patients with an anorectal malformation. Because at first, actually, the focus was on the reconstructive surgery itself, especially at the end of last century. Then we were all, as pediatric surgeons, thinking about the functional outcome of the reconstructive surgery we did. But the last decades, actually starting in the beginning of the 2000s, the quality of life has become a very topic of interest, and a lot of people perform studies on it. And with this interest, we also started to perform studies on sexuality in this patient population. And I think that's something that was a lot of times forgotten. If you look at the conclusions of the quality of life research, I think that's important to start with. You see that health-related quality of life is negatively influenced in many patients. Overall, general quality of life is considered good. However, most patients experience problems in certain areas, maybe in their body image or their self-esteem. And their quality of life outcome can be really influenced by their self-perception of the illness. And when you have an illness and you need to deal with it, you could have coping strategies, but maladaptive coping strategies are related to worse mental health related quality of life. And also the psychosocial well-being can be influenced in this population. And of course, that is a problem because if you look at it, about 20 to 54% of the patients with an anorectal malformation have also urogenital anomalies. These patients have had surgery in the pelvic floor and in the perineum. And also functional problems the patient still experiences can cause problems with sexuality. Looking at the urogenital anomalies that can be present, in the males, it can be a hypospadia, it can be a bifid scrotum, or there can be retrograde ejaculation, for example. In the females, more problems are there with the vaginal anomalies like a septum or even an agenesis. Uteral anomalies or a short perineum can be present. And those can be also causes for sexual problems. I would like to have a short talk on the research that has been done on sexuality in ERN patients in the last 10 years. And I highlighted some studies to show you the numbers of problems our patients actually experience. Because for me, it was an eye-opener after reading all this literature. The numbers are high, in my opinion. First, I would like to start with a big review article on the group of Andrea Bischoff. And she's talking about male sexual function, that she says that PSARFs, so more modern treatments, have shown to preserve erectile and orgasmic function better than older treatments. However, sexual dysfunction or impairment may still occur despite a good repair, maybe due to poorly developed sacrum, spinal cord anomalies, and other problems. What they found in their review was that erectile dysfunction ranges from about 14 to 41%. But more important in males as well is the fears that patients have during sexual intercourse. Will they have a premature ejaculation? Will they lose urine or feces? In the females, the sexual dysfunction is approximately 50%. That's really high. Of course, I know that in the population without an anorectal malformation, there is sexual dysfunction present as well, but that ranges around 20%, so this is really high. Dyspareunia is in 8 to 20% of the patients. And of course, the anatomic considerations may impact their sexual function, like a longitudinal vaginal septum, or an inadequate or a shortened perineal body. The group of Fischer researched the long-term male sexual function and fecal incontinence outcomes for adult patients with Hirschsprung and ARM. Looking at the ARM patients, again here, 45% of the ARM patients reported ejaculatory dysfunction, and it was less in the Hirschsprung patients. The ARM patients as well score significantly worse on the male sexual health questionnaire. And they say that ejaculatory dysfunction may be associated to fecal incontinence. The group of Paola Midrio, they have researched the testicular function and sexuality in adult patients. They evaluated 30 patients, of which 16 had rectourethral fistula and 8 erectile bladder fistula, so quite high fistulas. Complete dysfunction was reported by 1 patient, but ejaculatory anomalies again by 46% of patients was reported. Also 43% of their patients reported azoospermia. So they recommend evaluation of testicular function in all these patients. Then 2 studies from the Netherlands. They were performed around the same time. When you look back at it, we could have better put all our research together, but that was not the case. The first study of Desiree van den Hondel was about psychosocial well-being after childhood surgery for anorectal malformations and Hirschsprung. The ARM patients, about 16% of them have moderate to severe erectile dysfunction. The female sexual dysfunction and distress was 50% again, and 38% distress. But in both groups, 60% of the patients said there was a need for better addressing sexual concerns during their medical care. They experienced it, but it was never mentioned. my own study, were about the same numbers of the erectile dysfunction and the sexual dysfunction and distress in ERN patients, a little bit less dysfunction, 27%. But what we saw as well was that reduced perceived self-competence in female adolescents was associated with more sexual distress in adulthood. And in males, reduced perceived self-competence in romantic relationship and friendship in adolescence were associated with reduced sexual desire in adulthood. So that means that that there are already problems during adolescence and that's the period the child is still in the hands of the pediatric surgeon. So we should be aware of that. I'm actually now talking about my colleagues' colleague research. So Dr. Eleuteri and Caterina Grano, they were talking about sexual well-being in adolescents and young adults, and then the perspective of the patients. Females reported more fear and pain during sexual intercourse than males. The main problems in males were loss of feces and premature ejaculation, and the main problem and fears in females were the loss of feces, pain, and lack of desire and lack of lubrication. But only a few patients again asked their pediatric surgeon for advice. And then this is a really nice study, I think, and it's a good way of going to the next presenter, because the ARMNet Consortium has done a brilliant study led by Eva Amersdorfer about what do pediatric surgeons now think about sexual issues in dealing with patients with an anorectal malformation. And 82% of us thinks that they really should talk about it. So that's important. But 50% is saying, I'm not feeling comfortable, or I'm moderately comfortable discussing the subject. And 96% actually even says, I require more support. And 78% wishes to be trained. So a multidisciplinary approach in this is really, really essential. To conclude, to get your numbers in your head, erectile dysfunction can be a really, really big problem in almost 45% of all patients. Almost half of our female patients suffer from sexual dysfunction and sexual distress. Problems in adolescence are also associated with problems in sexuality in adulthood. Maybe the modern treatments have possibly less complications in this area, but many patients feel that no attention is being paid to the problems. And many pediatric surgeons need advice and help in the conversation about sexuality. So that is actually what I wanted to say about this subject. And now I want to hand over the word to Stefano Eleuteri, who can help us as pediatric surgeons and help you all how to deal with this problem with our patients. So thank you for your attention, and if there are any questions, I will be very happy to answer them after the next talk.
Hello, good afternoon to everyone. I hope you can see my screen.
Yes, we can. Great. Fantastic.
Okay, I'm really happy to be here. Okay. So let's see something about something more about sexuality in patients with anorectal malformation. So let's start from the definition of sexual health. In 2002, we had a new definition of sexual health that, as you can see, focus not just on the negative issues. It states that sexual health does not consist in the simple absence of disease, dysfunction, or infirmity, but we are talking of a state of physical, emotional, mental, and social health. So something that it is, of course, connected with well-being. So, of course, when we talk about this issue, we have to take into consideration that we need a positive approach that considers both physical, emotional, mental, and social aspects, and that take into consideration the fact that intimate and sexual relationships are very important in all people. So we know that sexual experiences usually are built step by step and the coitus is just one of these aspects. We know that, for example, the sexual exploration of children usually emerge in what we call the sexual games with other children, such also as the game of the doctor and the patient. We can see some issues in children and adolescents with anorectal malformation from this point, from this step of the development, because of course we can imagine that they could not be pleased to experience these games with healthy children because of the problems of continence, but also for the possible partially damaged body imagery that is connected, of course, with the hospitalization that they had during their life. These bring these people to have a starting point of sexuality that is quite different from most of the other people. In fact, what literature suggests is that at the age of 2022, most of adults with anorectal malformation had less sexual experiences than their peers. For example, the median age of the first sexual relationship is usually estimated at around 16 years, both in males and females. And of course, we can also take into consideration the fact that since sexual fantasies and masturbation are independent of sexual relationships, it may be that also teenagers with anorectal malformation achieve later the developmental tasks as a result of a lack of privacy. So all the studies that Marieke anticipated before are of course the results of these steps from childhood and adolescence that usually are different. And this is, as we anticipated, connected, of course, with the fact that usually in this person, the body can be perceived as indicted, traumatized, foreign, and so as a sick part excluded from the self. We can find in talking with people with anorectal malformation, issues that are related to the body representation, because of course the perception of the violation of the body with surgical interventions can be related to a loss of identity. The body, especially some parts, and especially of course the genitalia or the perigenitalia area, are perceived as sick, with also some worries that are connected also maybe to the form or to the size of genitalia, for example, for males, or also to negative judgments, because of course if one person do not feel to be adequate from a point of view, it will be difficult to share it with others. So of course what we often have is that these people has a loss of intimacy with oneself that can be the starting point for a problem also with sexuality with the others. So usually what we have in a normative development from a psychosexual relationship satisfaction is that one person accepts his her own body, should pass from a dependence phase to an autonomy one, and this is also another aspect that could be difficult for people with disability, because we know that usually the family of a person with disability do not give the adequate opportunity to reach the autonomy for an over control and an over protection that is of course not made voluntarily, but usually is something that come also without wanting these for the fear and for the difficulty that they perceive in their children. So it could bring some difficulties in building a strong sense of identity, and of course also to build a positive relationship and to experiment in the sexual area. We know that usually there are already difficult topics to talk with adults, like sex, masturbation, partner-related sexual activity, or fertility. And usually we can see that there is also a difference, a gender difference between boys that usually discover sex connected to masturbation, and mostly when they start a relationship, they have a few ideas that are mostly based on stereotypes. While in girls, masturbation usually is less frequent, also connected with a different anatomy of genitalia. They usually have a scarce body knowledge, and when they start a relationship, there is an idealization of love, and usually sexuality is just the consequence of love. So, of course, we can understand that these are the important areas that we should discuss with people with anorectal malformation. So the quality of life, the differences that they perceive to have with their peers, the body image for the things that we have already seen, the self-esteem, because of course the negative image of the body that they have could also have a result in the self-esteem, and then as a result the sexuality and the relationship. We of course can imagine that an anorectal malformation can influence both in the patients but also in the parents, the roles, the relationships, some aspects of the communication models for the overprotection that we have seen before, and of course the intimity and the sexual functioning. Marieke already anticipated most of the aspect that has a direct influences on sexuality, but we now see also some indirect aspect. For example, we have the fecal incontinence that sometimes can be connected to the erectile dysfunction, because of course if I am concentrated in avoiding the fecal incontinence, probably I will have less desire and it will be more difficult for me to maintain an erection. The fear of soiling during intercourse, sometimes also the urinary incontinence that we know is not diffused in all the anorectal malformation, but in some of them can be present. The modification in the body appearance and functioning. So, of course, this is sometimes a perception, sometimes we know that can be also real, that some functionings are not normative. Of course, this can bring with it the psychological distress, with the fear of being neglected, of being denied, and of course insecure relationship. Sometimes, of course, the role of the partner is really important, also because it will depend on the fact that the person will decide to share or not, for example, having an anorectal malformation, and this is of course depending also on the phase of the relationship. And of course the social image that usually people with anorectal malformation have is the feel of not being normal. So these are the most frequent problems in men and women with anorectal malformation, erectile dysfunction, problems connected to the perception of the penis, the size or the shape as we anticipated, because we know that in some cases there are, for example, epispadias or hypospadias, and this could bring problems in accepting and initiating a relationship. Retrograde ejaculation, so this could be also a medical problem, because this could also bring to infections, and of course dyspareunia and pain, also connected to the dimensions of the penis or the anus, depending on the kind of relationship that the person wants to have. We know that, for example, in women with anorectal malformation, the presence of malformed systems and related consequences could affect also the quality of life, the self-esteem, and the sexual well-being. And in this study, for example, some patients referred that they stopped also having intercourse because of pelvic pain or vaginismus that could also compromise their relationship. So one of the problems that the literature say is that usually there is difficulty in talking about this issue. You can see from this table from a study conducted in the Netherlands that most of doctors do not discuss of this issue. And here, in a study that we conducted in Italy, we had the results that most of the parents reported that they also did not have the opportunity to talk with the children, but they would be happy of some healthcare professional talking with them about sexuality. So, which is the problem in talking about sexuality? We know that usually medical doctors have some problems in talking about sexuality with their patients with chronic illness, also because this is connected with adolescents often, and it is difficult to discuss with adolescents of sexuality. In this study, we can see that which are the aspects that make it so difficult to talk about this issue with these patients: the scarcity of time, the fear of offending the patient, the shortage of communication abilities, few available and efficacious treatments, also increasing gap between the development of sexual medicine and the medical abilities. The discomfort, especially if the patient is of the opposite sex, this is a strong stereotype still present. There is discomfort if the patient is under 18, and also, of course, we already found it in a review that we conducted in 2020, an inadequate formation on sexual health. Regarding the patient's motivation to not discuss this issue with the medical doctor or with another healthcare professional, we have the lack of possibility, a sense of shame and embarrassment, some social taboos against an open discussion on sexuality, which is the uncertainty on the pertinence of sexual health in the care process, and also on who would be the professional who has to take care of sexual health. And of course, at the base of everything, there is a pessimism on the results of the discussion. Of course, when we talk about sexuality, we should take into consideration that when we take data on sexuality, we should take into consideration all these factors, so the biopsychosocial aspects and the timing of the problem. So the problem can be biological, psychological, or social, and the problem can be predisposing, so being at the base, precipitating, so being the last problem that the person can present, and a maintenance problem, so not the problem per se, but something that maintain the problem. So, and of course, so we should not never forget that also relational factors can influence on problems. So, of course, a biopsychosocial approach that can work not just on the sexual function, but also on the strategies of sexual intercourse and on sexual identity. So these are all the areas that we should investigate, the biological, the intrapsychic, the relational, if a relationship exists, and of course the couple dynamics, the family, and also the sociocultural factors. So at the end of this presentation, for this last 10 minutes, I will discuss something of what we can do in order to solve some of the problems that we have seen. For example, of course, it is always important to talk about sexuality. There is not an age where to start. Of course, we have to know that at every age we can discuss of something. We can take into consideration the guidelines of UNESCO that are free online. And we know that, for example, at 5-8 years, it is still important to know the names and the functions of one's body, and that it is natural to be curious about them, including the sexual and reproductive organs. So starting at an year where the child is young, we can start to build a confidence in talking about this. And this, of course, can be done by medical doctors, but also by parents. In order to explain the sex organs, we can use also anatomy tables that can be simplified when people are young or more difficult when they become to be older. Of course, when we arrive to 9-12 years, we could start also to talk about sexual health and reproduction, but also about something that is connected with them, like, for example, that everyone's body is unique and that variation exists in size, shape, functioning, and characteristic, in order to normalize the fact that they can be different from the others. Of course, it should be important also with them to talk about sexually transmitted infection, like we do in all different aspects of sexual education. It should be important also to talk with them about the use of condoms, because the literature say that usually when a person has more problem with sexuality, they will have less skills in order to negotiate, for example, the use of the condom. In this slide you find some stereotypes about the use of the condoms, while we know that there are no excuses for not using it, especially in the first relationships, and we can also discuss about all the different shapes and types of condom that sometimes can also be useful. For example, if some of them has a premature ejaculation or delayed ejaculation, we can use some condoms that can help with this problem. Usually it's always useful to explain how to choose a condom based on the dimension. because as we have said, sometimes they can have also different shape of their penis, and telling them that, for example, there are small condoms can help them to cope with this issue that can raise some anxiety, and of course also explain the importance of lubricants. Especially it is important this for females with anorectal malformation that can have also some problem in lubrication. Of course, it is another important issue to discuss with them is the fact that some of them may have also problem with fertility. So we can see that in the guidelines of UNESCO, they suggest to talk about infertility around 15 years, 18 years, to understand that not everyone is fertile and that there are different ways to try to address infertility for those who would like to conceive. And of course, there are also some suggestions that we can use in order to cope with the problems that we have seen before. For example, we can use some drug that can help for the sperm motility for the ones who have problem with this, or for the erectile dysfunction. Usually it's better to prescribe this daily and not on demand in order to avoid the perception of a mechanical sex, but of course this from a psychological point of view, but of course the medical doctor will know what to suggest on it. For the dyspareunia, we have already seen that the use of an external lubricant could help, while for a retarded or premature ejaculation, we have already seen that some condoms can help. Usually, if we find that this person can have sexual desire problem, it is always important to understand if it is a consequence of another sexual dysfunction. So it is always better to understand better and to understand which was the first problem. In order to assess sexual problems, for example, with the male, the medical doctors could use this simple tool, that is the IIEF 15, that can assess for all male sexual dysfunction. Another problem we have seen that it is how to manage loss of feces, and of course we could help the patients to name the problem, because naming it will help them also to differentiate the problem by themselves, help them to speak out of it with a sexual partner, so sometimes it is just a problem of communication. Try to experiment different sexual positions, because we know that the pressure on the abdomen can increase the pressure on the bowel, so it should be better, for example, to stay on side or on top. And of course, we know that planning the sex could help, because of course some people use some tool in order to manage the bowel, and so of course planning sex could be more useful for them. Of course, as always happen, if the problem is difficult to handle with this suggestion, it should be, from my point of view, important to consider to contact a sexologist. Nowadays, with the help of online therapy, it is always easy to find a sexologist expert in treating these issues, also in rural areas or in places where we don't know if a sexology is expert in this. So it is in this time more easy to have some help. When we talk of the sexual treatment, usually we try to discuss the possibility of renegotiating the partners, the mourning, the logistics of sex, the possible use of tools and toys, and of course the management of position. So I have already finished. So my take-home messages are that sexual health is important for overall mental and physical well-being, that the development of intimate and sexual relationships are very important in adolescence development, and that an anorectal malformation can influence roles, relationship, communication models, intimity, and sexual well-being. So it is really important to talk about sexuality with your child or with your patient. It is important to use empathy and to explain the sex organs, to talk about sexually transmitted infections, condom use, and fertility. Of course, it is important to help the person to name the problem, to experiment some possible sexual position, and to planning sexuality. So now I've already finished. I wanted just to invite you, if you want to discuss more about sexuality, we will have a congress now in May in Bologna. It will be the Congress of the European Federation of Sexology. So we will discuss more on how to treat sexual problems also in other diseases. And I leave you also my contact. So if you have any questions or comments that we cannot solve now, I'm always available. Thanks a lot.
Okay, thank you. Thank you to both presenters for that. So I'll just invite the audience now to ask any questions that you want by just simply typing in the questions field and then pass the questions on. Just while we're doing that, waiting for people to do that, just a reminder to all the attendees that you will receive a survey an hour after the webinar finishes. We'd be really grateful if you could fill that in. It helps us see how the webinars are going and direct our future ones. Also, for those who complete the survey, you will also get accreditation or receive an accreditation certificate for attendance today. Okay, so I've got, I think, quite a long one.
Can I add just something to your fantastic talk, Stefano? Because I really like the last part of your talk so much about how to discuss it and in what age group. And what I also experienced in the last couple of years is that it's so important to actually take the parents of the child from the day that the child is born with an anorectal malformation to bring the subject already to the table, actually. Because sometimes some mothers or fathers, they ask straight away, oh my God, but when my baby is older, can she have children or can she deliver? So they're already thinking about it. But sometimes the parents are really not thinking about the sexuality part or the functioning of, for example, getting an erection. So I always find it very useful, maybe at the age of 2 or something, just to ask the parents, or have you ever seen an erection in your baby boy in the diaper? Because that's, of course, sometimes happens. And then they're like, oh, yeah, I have. Okay, well, he has the anorectal malformation, he has been operated, so you know that part works. And then you see that they start thinking about the fact that it could be a part, it is a subject that they have to think about it as well, and to kind of take them with you, that they will talk more about it with their child. I always like.
Yes, I totally agree with you. It is important, yes, to discuss with them from the start, from when they are born, yes, in order to manage this issue.
I see that there is a question in the chat. it says, once a series of late follow-up contacts with your IRM patients have revealed that the patients suffer from various aspects of their sexual relationship, how would you propose to further handle these problems? And specifically, which professional would you advise to help the patient further with these issues you have described? The pediatric surgeon, the adult urologist, or should all of these patients be seen by a sexologist, as you suggested? Well, I kind of opinion about it. I do think that it is really important that when you start talking about these subjects with your patients, that you should have a backup. You should have other doctors involved when you can't solve the problem. So in my hospital, we have a very good sexualogist who is working together with the urologists, and they also see the adolescent patients, and I really like that. But I do also, I don't know how you think about that, Stefano. I do also think that at least when you address it already as a pediatric surgeon, I don't think that you can handle, of course, all the problems then, but you should have your sexualogist or your urologist with you in your clinic, or you can at least refer to them to solve the problem for the patient, or at least help the patient with the problem.
Yes, I totally agree with you. I think that all the team should have the competence to help. Of course, there are some issues that for me are typical, should be more typical for the pediatric surgeon. So, for example, the aspect connected to the development, the normalization of the aspect that we have seen when they are more young. When they grow up, I think that there should be the possibility to do a transition to a urologist or a gynecologist, but it should be important that, of course, they should be expert in understanding anorectal malformation. Because, of course, if they go to a urologist or a gynecologist that do not know anything about the anorectal malformation, it can be difficult for them to understand. So it will be, from my point of view, it is always important to make the possibility that the professionals talk together. So, for example, if you live in a place where there is not a urologist or a gynecologist that is expert in anorectal malformation, maybe you can put them in contact with your pediatric surgeon and let them to talk about what the child experience, which are the difference with the different genital organs or with the functioning, so that they could be help these. And from my point of view, often also the help of a sexologist could be useful, but of course it depends on the team, it depends on the need. We cannot generalize. In my perspective, for every sexual need, we always work together with a medical doctor, so a sexologist and a medical doctor together. But I know that in different countries there are different models, so you can choose and you can see what your country is offering, of course.
Yes, and in addition to that, what you said about the gynecologist is quite important as well, because in the last 10 years, we have changed our protocol, or at least 10 years ago, we changed our protocol a little bit, that when the child is born, we try to make an ultrasound as well of the uterus to see if there are uteral anomalies, and there will be a cystoscopy and a vaginoscopy during the surgery for the anorectal malformation. And when there is a problem, or when the patient, they have a cloaca, of course, but also when they have a rectovestibular fistula, we will send them always to the gynecologist when they are turning 11. And if the parents are in need for more information earlier, we do that earlier.
Okay, we don't have any more questions at the moment, so just while I ask people again, if they want to ask a question now, please do. If you think of anything afterwards, you're welcome to put the question into the survey. If anyone's watching back on recording, if you want to comment you should see various emails, my email available. You can also put comments onto the YouTube channel as well, and we'll try and endeavour to answer those as well. We do monitor those. Okay, and also, yeah, please do check out our YouTube channel and subscribe to it. You'll be then notified of all kind of future videos that are put on there. And also look at our website for future webinars upcoming. We will be updating that next week, hopefully. We just need a little bit of an update. But apart from that, yes, we've not got anything else. Okay, let's give people seconds. I have to say, oh, that's it, and then the question will turn up. So, so just give it a couple more seconds. But yeah, so thank you to everybody who's attended today, and thank you very much also most of all to our presenters for taking the time to do this for us. It's been most welcome. There's anything else you? Oh, I've got one question in there. I knew that would happen exactly. So I'll just put this one into. Really, it's not a question actually. It's just a comment which I'll send on to you afterwards. So it's not a direct question. Okay, well, thank you everybody. Yeah, sorry, the presenters again. Thank you very much. Was there anything you wanted just to say to finish off today, or?
I think this is a great webinar, so thank you.
Thank you.
Okay, well, thank you both. Yeah, if I forget any other questions, I'll forward them on to you for an answer. But yeah, thank you everybody for attending as well. Please, as I said, check out our future sessions as well. And I hope everybody has a great evening. And thank you very much.